So welcome everyone to today's Public Health Unit Immunisation Catch-Up webinar. I'd like to start with an acknowledgement. We acknowledge the traditional owners of the lands on which we meet today and pay our respects to elders past, present and future, for they hold the memories, the traditions, the cultures and hopes of Aboriginal Australia. If you have any questions throughout the session, please pop them in the chat or Q&A, and if we have time, we'll try to answer these at the end. Any questions we don't get to answer, we'll get Cindy at PHU to respond, and I'll send the answers out with the slides and the recordings. We would appreciate if you can complete the evaluation form that will open up when you leave the session this afternoon, just to ensure that we continue to provide relevant information for you. As mentioned, we will be recording today's session, and I'll be able to provide a copy of the recording along with your certificate of attendance and the slides. These will be sent out to the email address that you registered with within the next couple of weeks. Just wanted to put a disclaimer out that each state has a different immunisation program governed by their state public health unit. So the information provided by the Queensland Health Public Health Unit may not be relevant to some people attending from other states. The information provided at this webinar is specific to Queensland, and we recommend that you check with your local state public health unit for localised information. And now I'd just like to introduce Cindy from Metro North Public Health Unit. Cindy's a clinical nurse, and over to you, Cindy.
Thanks, Amy. Can you hear me all right?
Yep, thank you.
Okay. Hi, good afternoon, everybody who's tuned in to listen to this update. Thanks so much. I'm sure you're all busy and you've taken a bit of time out of your busy day and your lunch hour. And I'm going to just try to share my screen here, so just bear with me.
Yeah, that looks good. Thanks, Cindy.
Is that all right, Amy?
Yeah, thank you.
Yep, lovely. Okay, so this is, as is advertised, is an immunization update for October. We're going to talk about a few things, the new vaccines that are coming up, which I'm sure you're all are aware and wondering about, specifically the Vaxelis, the Shingrix, the meningococcal B. We'll just review vaccination for adults and the school immunization program. One little tip for Lyssa virus about requesting immunity testing we'll go over, and then just a few pointers about AIR, the catch-up calculator, and a few other quick points. So Vaxelis, I'm sure all of you are aware now, probably have it in your fridge. As of 1st of July 2020, this was added to the National Immunization Program.
Cindy. Your screen, there we go, that's fine. Cool, thank you.
Is it all right?
Yeah, that's fine now, thank you. It was just taking a while to transfer to the next slide.
Oh, right, okay.
Okay.
Yeah, okay. So 1st of July 2023 was added to the National Immunization Program. This is an alternate vaccine to Immunisation Hexa. It's not a replacement. The recommendations is it's best to use the same vaccine for all 3 doses. So that's either the Vaxelis or the Hexa. But if that's not possible, then the alternate can be used. So you can still sub in one or the other if that's what's available. This can be used for catch-ups to under 10s. There's no reconstitution with this one, which is a big advantage, I guess, over the Immunisation Hexa. 0.5 mils intramuscular, 2, 4, and 6 months. Has that screen advanced?
It's, no, not quite. It's kind of like merged. but can you click on it again?
Yes.
There we go. And now
Oh.
it's moved. Okay, now go back. Yeah.
Sorry. Is that clear now?
Yeah.
Excel
Thank you.
preparation. Okay, I'm not sure what the problem is. I apologize. So this is just a kind of side-by-side comparison of the two vaccines. You may get one or the other or both at any time. So maybe most of you have seen them already. It shows you the bits and pieces in each one, the colors, so that you're aware. And I guess the big difference is the Vaxelis does not require any reconstitution. Of course, both of them are light sensitive. We recommend that you keep them in their original package at all times for easy identification. Has that advanced the screen?
Yes, that's great.
Okay, I think that one works better. Okay, so I guess there's just a couple things. Of course, Vaxelis sounds very similar, looks similar to Varivax and Verilrix. So this is just, I guess, a word of caution that label them clearly, and I suppose separate them in the fridge or have some way to differentiate Vaxelis from the varicella vaccines, because you don't want that mix up. Just for your information, FYI, that's the practice software code is Vaxelis. Yeah, that was just for your information there. Then we'll move on to Shingrix as the new shingles vaccine. So just a little bit of overview about shingles. All this information is pulled from the Australian Immunisation Handbook and the National Centre for Immunisation Research and Surveillance. Primary infection with chickenpox or varicella. Once it's resolved, it remains dormant in the nerves for years and then reactivates. And this is what causes a shingles episode. And that episode can occur for no apparent reason. So persons with shingles will have a localized painful vesicular rash resulting from that reactivation of the varicella zoster virus in their nerves. Usually it's unilateral following a dermatome distribution, most commonly in the lumbar thoracic region. Usually it lasts 10 to 15 days. There's some prodrome that precedes that with a bit of itching or tingling. Usually it's self-limiting, but it can lead to some side effects, the most important being the post-herpetic neuralgia, which is also PHN and not Primary Health Network. Same acronym. PHN is a chronic neuropathic pain syndrome. Or long-term nerve pain, you can also refer to. It's defined as pain that persists beyond 90 days since the onset of the rash. It can last months to years, and the pain can be severe enough that it interferes with someone's daily life. 20 to 30% of people will have shingles in their lifetime, most after the age of 50. The age-related decline in mast cell immunity is the most important risk factor for getting shingles. So those over 70 years are also noted to most likely have complications. Antiviral medication will speed up the healing of the lesion and reduce the acute pain, but treatment may not reduce the likelihood of the PHN, the post-herpetic neuralgia. So zoster vaccines, while they're not a treatment for shingles, so you wouldn't give it when somebody has an episode, they are used as a prevention, a fairly effective prevention of both shingles and of the PHN. So a national sero survey in 2007 showed 95% of the adult population in Australia had antibodies to VZV, which is the varicella zoster vaccine, by the age of 30. So that means almost the entire adult population is at risk for shingles. Subsequent or second or subsequent infections are not uncommon. The incidence of shingles is much higher in people who are immunocompromised, which kind of takes us into the reason for the Shingrix, because as we're all aware, the Zostavax, which is what we've previously or currently been using, is not appropriate for immunocompromised persons. So they're kind of left unprotected. So Shingrix now has come on the market. From the 1st of November, it's already on the private market, but from the 1st of November, it will be available on the National Immunization Program. That's the latest information that we have. I think it was slated to be released earlier and then it got a bit delayed. So as of now, it's expected to be the 1st of November. It will replace Zostavax, so you won't have both. It will be one or the other, although you're advised to continue to giving Zostavax until the 31st of October 2023. What is Shingrix? So it has a very long kind of title. It's an adjuvanted recombinant VZV glycoprotein E subunit vaccine. And I've kind of tried to give a little explanation of what all those words mean. So it's essentially, it's a little piece of the virus DNA that they've reorganized, attached it to a carbohydrate protein, again, a subunit, which is another fragment. So it's little bits and pieces of the varicella that will then give a good immune response. So the big advantage of this, it does not contain live virus. So for that reason, then it can be administered to people who are both immunocompetent and immunocompromised in the eligible age groups. It's a 2-dose schedule, which is different than the Zostavax, with a gap. You give it IM, and there's a 2 to 6 month gap between those 2 doses, and there's no booster dose. It's 0.5 mils reconstituted. In the Australian Immunization Handbook, it is actually recommended for all persons over 50. So anyone who wanted to protect themselves who was over 50, it's advised that they take the Shingrix. It's been available in Australia from June 2021 on private script. So some people have already been getting it privately, but it's available from the 1st of November on the NIP. So that's the funded vaccine. And the groups listed are 70-year-olds only, all non-Indigenous, 50 plus for Aboriginal and Torres Strait Islander persons, and 18 years plus for immunocompromised at high risk of the herpes zoster. So it's not quite clear about catch-up. I know everybody's going to ask if they're 71, 72, can we give it? But we don't have a clear direction yet on that. I'm sorry, we did inquire from the Queensland Immunization Program before putting this PowerPoint together. We didn't get an answer. I think things are still being worked out. So we will give you that information when we get it. But as far as we know, there's no catch up at this point. So it can be given to those who are previously vaccinated with Zostavax. But you need a 12-month wait. So if someone had Zostavax, and of course, that's not the funded one. If somebody privately had purchased Zostavax and they had it in their 50s or 60s or something, or just whenever, it needs to be a year for you to then go ahead with the Shingrix. And if someone's had shingles, an active episode of shingles, then again, you're advised to wait 12 months. So the vaccine efficacy, so 2 large trials of Shingrix, the prevention of shingles episodes was 97%, which is very high, of immunocompetent persons age over 50. And the protection against the post-herpetic neuralgia was also high at 89 to 91%. So it seems to be a very effective vaccine. It's shown to have better and longer protection against the shingles infection compared with Zostavax. It may have more protection. Okay, yes, that's what I said. Also for PHN. So both shingles infection and PHN appears to be better. The duration of protection for immunocompetent is as above. It's not as clear for the immunocompromised persons. So from that one study that they looked at, there were high rates of protection against the herpes zoster shingles for 4 years after vaccination. Other data suggests still a good immune response after 10 years. And the waning protection from Shingrix appears to be slower than that of Zostavax. There are some adverse reactions with Shingrix. So both your local and systemic adverse reactions obviously are more common than after placebo. You do have kind of injection site reactions in about 82% of at least this was in the trial when they ran the trial. For systemic adverse reactions, fatigue, GI symptoms, headache, shivering, myalgia, about 66%, excuse me, of persons had one or some of those. In about 10% of persons, those side effects might be severe enough to disrupt their day, but will resolve without treatment. So someone might have a headache or fever and feel that they can't, go to work, or they need to lie down for the day, but it will resolve. So I think the thing here, because the adverse effects or side effects are a little bit stronger, some persons might fear that they don't want to get the second dose. So I guess it's important to say those things up front, that to inform your patients that sometimes happens, but to get the full protection, they will need the second dose. So it's to kind of push through those side effects so that they don't end up being underprotected. And so, yes, for some reason, the side effects are a little bit higher with this compared with the Zostavax. Data from the US suggests also a very rare association with Guillain-Barré and Shingrix. There were 3 additional cases per 100 million, per 1 million doses administered. But episodes of shingles can also trigger GBS. So the conclusion is still that the benefits of the vaccination do outweigh the risks. Meningococcal B, we'll move on to that one. So invasive meningococcal disease, which is referred to as IMD, as I'm sure all of you are aware, is a rare but serious bacterial disease caused by Neisseria meningitidis. That's the name of the bacteria. The most causative serogroups are A, B, C, W, and Y. And 10% of healthy persons do carry the bacteria in their nose and throat, and unknowingly they spread it to others through close prolonged contact, and that's either droplet or direct contact. Most people remain well, but there are a few people who become ill with meningococcal disease for reasons that are not fully clear. This is why meningococcal is a bit sporadic. It just occurs one case here and there, and it's no really way to kind of know where it came from. It occurs in usually 2 forms, either a meningitis version or the septicemia version. And both can rapidly progress to someone being extremely unwell or even dying. So just a few statistics to show you, especially about meningococcal B. So this is from the Australian Meningococcal Surveillance Program 2020 report. And then you can see by state, Queensland has more cases than the other states. So that breaks it down both by the serogroup, but here on this slide, at least I'm looking mostly at the main or the total amount of cases per state. So I don't know the reason for that. I'm sorry. But this is the statistics that the program is being kind of based off of. And then this, the same from the same report, is another table that shows you now the breakdown by serogroup and by age. So the B serogroup currently for this group's under 1, 1 to 4, and 15 to 19 is the highest, are the groups with the highest number of cases of meningococcal disease, and that's related to B. So the others have kind of all, there's hardly any cases, 1, 1, 0, 0, but B at the moment is the most significant. So in early 2024, the Queensland meningococcal B vaccination program will start up and provide free meningococcal B vaccine to the eligible Queensland infants, children, and adolescents. So currently we have in the NIP, Aboriginal and Torres Strait Islander children under 2 get the meningococcal B vaccine. And what's going to be topped up on top of that by the Queensland program is all other infants 6 weeks to 12 months. They will get the meningococcal B. They will be catch up for all other children from 12 months to 2 years. So similar to the current system for the Aboriginal and Torres Strait Islander children. And the adolescents are also going to get it 15 to 19 years old. And it's going to be put into the school program so that they all have easy access to that. So the question is why? Why is this program being started up? Just quickly to first say that the Australian Immunisation Handbook, in fact, recommends meningococcal B vaccines to all infants, children, adolescents, and young adults. So regardless of who you are and whatever, it has always recommended that everyone should in fact be vaccinated. There's improved vaccine control of the other strains, as you've seen on those previous slides of A, C, W, and Y with the current program, since we have vaccines covering those strains. And meningococcal B continues to cause the most disease in Australia. The infection, of course, is very significant because you can have permanent complications or death. As it's already available for the Aboriginal Torres Strait Islander children, but that's because of the statistic that they are 4 times more likely to get invasive meningococcal disease than other Australian children, which is why theirs has been funded up to now. A state-funded meningococcal B program was introduced in South Australia from 2018, and they saw a reduction in meningococcal B disease in South Australia. And perhaps Queensland has also then gone ahead based on that, the results of that program. So across Australia, the Men-B vaccines have been privately available, but are expensive. And I'm sure you're all aware of how much those cost. Therefore, the Queensland Men-B vaccination program aims to reduce the financial barriers and improve uptake across the whole cohort of children and adolescents. So Bexsero dosing, that's just a little picture there. You all know, I'm sure, how it looks like. It's the same schedule as with the Indigenous children, babies 6 weeks to 11 months without medical risk factors. It's a 3-dose schedule, 2 doses under 1 year, 1 at 12 months plus. Babies 6 weeks to 5 months with medical risk factors get an extra dose, 4 doses in total. Babies to 6 months to 12 months with medical risk factors. So that depends, of course. The difference depends on when you start. If you start very young, you end up with an extra dose. If they start at 6 months, they still get the 3 doses. So the catch-up So babies over a year would just have the 2 doses separated by 8 weeks. And that will be the schedule for the adolescents who are greater than 10, also 2 doses separated by 8 weeks. So some of the common questions we're already getting, because people already are kind of getting aware that this is coming up. And this I've taken straight from the web page, which you can all look up, Queensland Health. Just Google Queensland Men B vaccination program. Can people who are not eligible for Medicare have the vaccine? The answer is no. It's just for just for Medicare registered persons and children. Although refugees and humanitarian entrants, for those of you who deal with that population and are Medicare eligible, can also be vaccinated under this program. Visitors to Queensland, can they be provided with this vaccine? The question is also no. The Queensland Men B vaccine is for residents of Queensland who are Medicare eligible. Can I be reimbursed if I've already paid for the Men B vaccination? No. Reimbursement is not available to those who've already accessed the vaccination prior to commencement of the program. Why can't the Queensland Men B vaccination program begin sooner? We've had multiple calls already about this here. We're not the ones running the program. We're just conveying the information from the Queensland Immunisation program. So the Queensland Men B vaccination program is the largest state-funded immunization program ever implemented in Queensland. So nearly 500,000 infants, children, and adolescents will be eligible to receive the funded vaccine starting from the first quarter 2024. There's a bit of lead time that's required to put all the logistics in place, ensuring sufficient vaccine supply for all eligible people. So just so you know, that's the official position. I know there'll be people who want to start it now. It's going to start in a couple months. Why can't we just start now? But that's the reason, is that all the logistics and the supply pipeline is not yet fully there. But you can find all those answers, and you can refer any patients also to that website if they want those answers. Just for your awareness also, there's another meningococcal B vaccine, Trumemba. I don't know if anybody has seen it or used it. It's just for your awareness that there is another one out there. It's only for persons over 10 years. It's a 2-dose schedule with 6 months between the doses. It's available on private script. It's not interchangeable with Bexsero. It's not on the NIP program or the Queensland Men B program. I just mentioned it because perhaps some people are getting it on private script. You might see it come through your clinic at some point. Okay, so we'll just go through just a review of the vaccinations for adult Australians. COVID, influenza, pneumococcal, zoster, which we've already covered, DT boosters, and MMR. So the current COVID vaccination recommendations, as you know, everything with COVID changes every 5 minutes. So at the beginning of the year, there was the 2023 COVID-19 booster dose. So that was the February 2023 guidelines, which is in yellow there. You can see that. The recommendations were for adults. Let's first say no risk factors was really just for 65 plus was recommended. And anybody 18 to 64 could consider it, depending on their individual situation. So since then, in September, in the green, there's been another, what they're calling the additional 2023 booster. And that is now recommended for adults who are, let's say, with no risk factors, 75 plus. So if you have someone who's 75 plus, they had already their booster earlier in the year, they still need that 6-month gap, which I'm sure everybody's aware of. You need that 6-month gap from the last one to this one. So if they got it early in the year, and they're over 75, it is recommended for them to have another one. So that table, you can get that in the, I think it's in the, well, this is the ATAGI one, but it will be also in the NCIRS updates. And then you can just look at your, however old your person is and whether they, the vaccine is, the second booster is considered. So it is considered as if they're 65 plus and they have some issues, then it should also be considered, but definitely over 75 recommended for all. So it's mostly the elderly. As this point at the very top here, older age remains the strongest risk factor for severe COVID-19 disease, which I suppose is why that has been added after the fact. So that's just the ongoing COVID thing that never seems to end. Adult vaccinations continued. So influenza, I'm sure you're all aware, annual influenza is recommended for anyone about 6 months of age, free to those who are eligible. That changes all the time. You know which ones are eligible. And then we had that bonus halfway through the year where everybody in Queensland was eligible, which is now finished. So yeah, that one is always ongoing. Pneumococcal, which is on the schedule, adult schedule. Individuals, let's say, with no risk, they're obviously getting their 1 dose of Prevnar. And then and then those with medical risk conditions have that slightly different program where they'll have their single dose and then the Pneumovax 5 years later. So that's also ongoing. It's just for your awareness to keep that at the back of your mind. There are some new pneumococcal vaccines that are coming onto the market. There's 2 new ones that are approved by the TGA, Prevnar 20, which is 20 variations, registered for, at the moment, 18 plus, and another one, different manufacturer, Vaxneuvance, 15 different strains, registered also for 18 plus. So the comment in the official documents is that the optimal pneumococcal vaccination program for Australia is currently under review, and they're looking at these new vaccines. The extended valency vaccines, they call them. They're recommended, so they are recommended, but they're not currently funded. I'm not sure if they're available in pharmacies. I tried to have a quick look. I couldn't really get that, so I don't know if any of you have seen those already or not. Currently, only the Prevnar 13, the Pneumovax are funded under the NIP. That might change in the future as this review continues on. So you might see those come in the future onto the NIP. Zoster, we've discussed already. DPT, the tetanus booster. So a booster of tetanus-containing vaccine is recommended, though not funded, under the NIP for adults over 50. So if they hadn't had a tetanus vaccine in the previous 10 years, but have had a previous primary course, they should have a booster. If they have, though, of course, a tetanus prone with more than 5 years has gone by, then they should have the booster at 5 years if they have a big injury. And a single booster of a pertussis-containing vaccine is recommended for adults who are 65 years plus, who have not received a dose in the previous 10 years, especially those in close contact with infants less than 6 months, if more than 10 years have gone since the previous dose. This is all in the Australian Immunisation Handbook. I just pulled it out just to, emphasize a bit. MMR also. Any adults born during or since 1966, if they do not have 2 documented doses of MMR, they can get those doses for free on the NIP that's provided. That's also on your schedule on the wall, the poster. And the catch-up is funded under QIP. So that's not in all states. That's, I think, that's Queensland. So the school immunization program 2024, just an overview so you're all aware, because of course you deal with all these teenagers all the time, and a lot of them come to you if they don't do the vaccines in the school program. Year 7, we're now up to just 1 dose of HPV and the tetanus pertussis booster, Boostrix or Adacel. So usually they'd get that on 1 day. And then in year 10, it's going to be the meningococcal. So the ACWY, which is 1 dose, and the MenB is the one, of course, now being added. Bexsero, which is 2 doses. So whoever the provider is to the school for those vaccines will sort out kind of the schedule, but they'll get 2 doses at least 8 weeks apart, but it could be several months depending on how they schedule their visits to the school. So those who do not have the vaccines at school can get them at their GP. And please emphasize to parents, if you're giving kids their school vaccines in general practice, please emphasize to the parents that they can decline those forms when they come around, that they've already had their teenage dose, so they therefore don't need it. But if there's any debate or any unsure, please check AIR. The people providing the school vaccines must put everything on AIR also. So the AIR should be fully up to date. So lyssavirus test request. This is just an FYI, please. I know nurses who order this, but we get this multiple times per day. Lyssavirus test request is notifiable. So before they even run the test, it gets notified to the public health unit that someone has requested this test. So in the background, we usually have a look at the forms, the pathology forms. If we see on the form this statement here, no Australian bat lyssavirus or rabies exposure, we don't have to call you. Most of the times it's just written immunity check or checking immunity. That's not enough for us. And that's why I'm sure you've all had calls from us asking what was the test for. So the difference for us is we would follow up anybody who actually had been bitten or scratched. But if somebody's just doing routine immunity checking for their work, maybe they work in vet or they work in a lab, or they're travelers, if they just want to know that their immunity level, then we don't need to know that. But if it's clearly written on the form here, then we won't have to call you. That's enough information to us to say that it's not a case that has to be followed up. So we just wanted to put it out there because it happens a lot, and we end up calling the nurses, even though they're not the ones who order it. I know. But anyway, if you can just inform your doctors to put that little statement there, that will make everybody's life a lot easier. AIR and the catch-up calculator, just a couple points. AIR, so some people call us about challenges recording persons with no Medicare number. You can enter persons with no Medicare number. Some of you may be aware and know how to do this. Some of you haven't done it before. So the main thing is first search for the name using the name, date of birth. If you don't get anything on that search, do the search again and try to add the postcode. Sometimes adding one more piece of demographic will find that person. If that again fails to give you a file, then you go to the bottom of that right page in AIR and select the recording counter button. Complete all the fields. You fill up the address, gender, Indigenous status, click next, and then you will be able to enter your vaccine. A lot of times, of course, this is in babies who maybe aren't yet on AIR, but AIR has a information that if when an infant is automatically registered to AIR once they're enrolled in Medicare, so any vaccines recorded prior to that will be merged under their record. And then AIR partially processed. Now, this sometimes when you give vaccines early or it's not on the schedule. There's sometimes this code that comes up when you're looking at AIR on the user's page, not the PDF page. Those partially processed vaccines will not show up usually on the PDF page. So yes, if there's an issue with that, a lot of times I'll just, for an example, this will be something like the rabies vaccine, which is 4 doses post-exposure. So sometimes the first or the third dose, because there's a very small gap between those two, will not show up. It'll say partially processed. And then when you print out the PDF, it looks like they've only had 3, when in fact they've had 4. So I guess the point is just that if you see that, you sometimes will have to call AIR and ask them to sort it out if it's something that can be sorted in that way. So just check about that, because everything might not show up on the person's when they pull up their MyGov records. It might be missing some of the information just because there's some kind of technical glitch in the background with AIR. And then recording your overseas vaccination. This is just a screenshot of that page. For those of you who have entered things into AIR, you'll understand all this. If it's overseas, of course, click the first block, the overseas, it was performed overseas, which country, what date. In this box, if you don't know the brand, if it's a generic, I just put generic tick-borne there, but if you put generic, start typing that, it will pull up all the generic vaccines. So if you don't know the brand, just put generic, whatever it is. If you don't have the batch, it's fine. Put no, not recorded, no space. If you put a space there, it won't let you go further. Just put not recorded in one word, no space, and you'll be able to log that vaccine on that person's record. The catch-up calculator. So I just inputted a kind of a dummy person, 7-year-old unvaccinated, just to get an example report. Again, some of you might have used this, some of you may not have. It can be helpful a bit, especially if you're new to vaccines and catch-up. You do have to enter a lot of information, but this is essentially the report that you get out of that. So we just wanted to highlight a couple of points of what we get questions about. First of all, the $sign in red, that means that it's not funded under the NIP. So for this 7-year-old unvaccinated child who I put in here, varicella, they're recommending it, but it's not paid for. That's the second dose. Okay, the first dose is funded. The second dose is not, but it's recommended. So they've entered it into that catch-up, but you would just explain to the parents they would have to pay for that if they want to do that. The second point is the grouping of the vaccines. So the way that this calculator groups them, so it's put, because this child is 7, it's suggested that this person should have the diphtheria, tetanus, pertussis, polio, which is Infirix IPV, or quadricell, and Hep B. So it separated them out because that's, if they had started as babies, that's kind of more appropriate. But I guess the issue for us at the Public Health Unit and per the Australian Immunisation Handbook is that you wouldn't give the Infinrix. You can, it's not wrong. You can give the Infinrix IPV and the hepatitis B as 2 separate doses. We would recommend you to give just the Infinrix hexa. So at this age, at 7, they don't need Hib, as all of you are aware, I'm sure, but there's no harm in giving them Hib. And the advantage if you use hexa in this case is that you now reduce the number of needles by 1. So you'll get all of this in 1. And this is going to be someone who's going to need to do this 2 or 3 times, right? If they haven't had anything. So instead of giving 6 needles, you're going to give 3 in the total, end. And they'll get a Hib dose that they don't require according to the calculator, But as it says in the AIH, some people need further doses of antigens that are only available in combination vaccines. It's acceptable to use the combination vaccines, even if this means that the number of doses of another antigen exceeds the number required in the schedule. So this person at 7 doesn't require HIB. It's fine to give it. You'll actually reduce the number of needles this child needs. If you have any problems with that, just call us if you're using this calculator. It's a guide, it's a good guide, but sometimes it's better to lump them all together, even though it seems to not direct you to do that. So a couple other points. Travel vaccines and schedules. We get a lot of calls about travel vaccines. Our expertise is around the NIP vaccines, not travel vaccines. So we don't really give much recommendation about those. We would refer that the person sees a travel doctor or a travel nurse, refer to the Australian Immunisation Handbook. smarttraveler.gov.au gives which vaccines are required for which countries, and the CDC Yellow Book are all good references, but we don't generally give a lot of information about travel vaccines. Early vaccines because of travel. This is another question that comes up. If the minimum age of the minimum interval is not met. So sometimes people travel overseas and they want to do their vaccines early. They want to do the MMR early before 12 months or before, if the minimum gap is not respected. Just FYI, you can do them early if you feel compelled to do that and your doctor thinks that's a good idea. But if the minimum interval is not respected, it will be invalid on air, and then there could be implications for the child care benefits. So that sometimes happens. People don't realize that's the implication. So another dose might be required. Just again, so you're aware that those getting early vaccines may have that kind of knock-on effect, which people get surprised about. Catch-up schedules. Please do as much as you can before you call us. We're happy to help with catch-up schedules because they are quite complicated sometimes and tricky. But see how you go, trying to figure it out yourself. Again, you can try the calculator if you're not used to doing catch-up. We have some templates here, like paper templates or PDF writables that you can we can send you. So if you need those, they help to advise you on how many doses of each antigen children need at the age that they are at. So they're quite useful, and we all use them here when we're giving advice to you guys on the phone. We usually work through those worksheets. So if you need those, let us know. Give us a call. We can send you those. And then we also do regular immunization updates via the PHN newsletter, and which is sent to all GP practices. So little tidbits, just short updates come out regularly. So have a look for that newsletter if you don't regularly see it. And that's everything. Sorry for talking for a long time. I think with the questions, those I guess will go to Amy. And I will unshare my screen here if I can. Oh yes, there's a page of references also that will come when we send you the copy.
Okay. Thanks, Cindy. So we've got a couple of questions here. And I'm sorry, Susanna, I'm not entirely sure. This was one of the first questions, so it might be refer to what you were obviously referring to what you were talking about in the beginning. But the person's asked, is it a single or multiple dose?
Which one?
Yeah, I don't know.
Oh.
It was when you were talking in the beginning. I'll go on to the next question at this stage. Can you please clarify that Shingrix will not be available for free on the NIP for anyone 71 years and older? Is it strictly for 70 years of age?
As of now, yes. So that's what I said. We've been trying to clarify if there's a catch up. We don't have any direction about that now. So as of the information today, it's for 70 years all non-Indigenous, not 70 to 79. There's not the current catch up. There might be one, but no, as of now, there isn't.
Okay, and that question actually came in at the same time as the other one. Is it single or multiple dose? So I don't know if that jogs your memory.
Yep, Shingrix is 2 doses separated by 2 to 6 months. So the previous one, Zostavax, was one dose, and this one is a series of 2.
Next question: if a teenager had a private dose of Men-B in infanthood, would it be recommended to give them a booster age 15 to 19 under this program?
I guess they have to look at the whole if they completed the whole series or not. The meningococcal B kind of schedule questions are quite tricky. We were talking about this before in our office this morning about how to do all that, because some people will have had one and then yes. So look, we'll have to look probably at all of them individually. The whole argument would be to continue the original series that they started on. So whether that's 2 or 3 doses, then you wouldn't give a booster if they completed the whole primary series. But if someone had partially completed, I think we'd have to look at that as a case-by-case basis and see what age they were at and what age they are now. But yes, the argument is always to complete the whole schedule.
Thank you. After recording an encounter, sometimes it still comes up that the patient is not found. What should be done then?
Yes. The search on air is always a little bit challenging. And sometimes you've entered somebody and you can't get them to come up again. I'm not sure what that's about. If you have problems with air, then you'll have to call them on that number. If all the data, if you've entered all the demographics completely and you're quite sure that's correct and they're not coming up, then you'll have to call that the air number because it should be there. You should be able to access it. Perhaps some of their information has changed in the background and you're not aware. Maybe the Medicare number has changed and it's changed their address or something. So yes, any of those issues you will have to call air directly. Sorry.
Yeah. Is there any more news on RSV vaccine?
So we don't have any news yet. The vaccine's in the pipeline. I think it's already rolled out in some other countries. There's nothing that we have at the moment about RSV vaccine in Australia.
If we still have stock of Zostavax after 31st of October, do we discard them?
So good question. We haven't been directed what to do with the stock of Zostavax. You are, regardless, you'll switch over to the Shingrix as of the 1st of November, according to what the program. And I think we will get information about what to do with that Zostavax, whether it's going to be discarded or returned to QIP. Also, we don't have that information yet. So hang on to it for now. Keep it safe in your fridge. And I'm sure we'll get information of what to do with that.
Okay. I had a request. Are you able to send the templates for the catch-up planning together with the slides of the seminar today?
Yes, we can do that. I can send that to you with this PowerPoint. Yes, that's fine.
Great. Thank you. DTP vaccine for older people, is this covered by NIP, i.e. those close with infants, i.e. grandparents, fathers?
No, that's all privately funded. There's no, years ago we had the grandfathering something. It was, what did we call it? There was a name for it. Anyway, but that is quite some years ago now. So parents and fathers and grandparents do have to privately purchase that Boostrix or Adacel.
will the meningococcal B vaccine catch up be only for under 2? So when they are already turned 2 years, they will need to pay for the vaccine. That's a question?
Yes, as of now, yes. The catch up isn't go above 2. It's only for under 1s, and the catch up is 1 to 2. So there's not another catch up for other age groups.
When we are able to order Shingrix, do we select how many we order?
I don't know. Normally, Quip gives you, I think, what they think you're going to use. You'll just have to see what happens when they start sending it out, whether it's enough for you or not. If there's a place to request on the form how much you want, you can take your chances, but I suspect they will just allocate, obviously, because they're going to be initially sending out to everybody. It's probably, there's probably some set amounts that they've decided on, but that's Quip. That's not from our office. So that I'm just kind of guessing is how that will go.
Okay, thank you. And the last question, just wondering whether we will have, oh no, somebody's just typed in. So second last question, just wondering whether we will have or have any information regarding flu and COVID combination vaccine next year, or is it still separate vaccines?
As far as we know, it's still separate. We haven't heard of a combination vaccine yet. I'm sure there's a lot of vaccine companies working on that, but no, it's as of now, they're still separate.
Just regarding that question about meningococcal B catch-up, does that include patients who have already commenced, for example, patient coming in for their 3rd dose?
So if they, yeah, again, it'll be on an individual basis. If they started the schedule in the normal time under 2 years, and now they're over that, as long as they started the schedule in the time frame they were supposed to, then the whole schedule should be given. So like I said, it's a little bit hard to articulate every individual scenario. If you have any questions about individual cases, you might have to just email us, and we will try to work through that with you.
And somebody's just mentioned the whooping cough program was called cocooning.
That's right, cocooning. Yes, the grandparent cocooning.
Yeah. So that looks like that's all the questions. So everyone, thank you for coming along today. As I mentioned earlier, the recording and the slides I'll send out to you along with your certificates of attendance in the next couple of weeks. And Cindy, if you could supply those templates, that the catch-up templates, I'll also send those through. And again, if everyone could complete the survey that'll pop up when you finish, just so that we can make sure we're continuing to give you the all the relevant information. So thanks everyone for joining. Have a great rest of the day.
Thank you, Amy. Thanks, everybody.
Thank you. Bye.
Thank you. Bye.